Are you talking? I'm not. That's so cool. How do I get eating camera? Oh, no, it's back.
Continuing. I was going to step out. How far can I go before the other room can still see me? I can go to there, yeah? Test. It works. All right. Merry Christmas. You guys are looking festive. Welcome to the other room. So you guys realize that there's a whole other room of you somewhere. Virtual. I think they're over there. You probably met them during dinner. So I just want to get us started by acknowledging the passing of Tom Bailey. Yeah. So Tom was very important to us being here tonight. He was the co-chair of RCI, which is running the RCI series that we're at. And so we just feel like it's important that we remember how important he was to us. I think so many of us knew him as a friend, mentor, leader, shining example of good behavior and doing things right and thinking of patients first. So this is our moment where we say thank you to him. We remember him. We acknowledge that he had an important place in our lives. He left quite a gap in our hearts, and so we're all working through that. There's a gap in our leadership, and we're working through that as well. But we will bring his spirit here, which was, hey, let's work together to make patient care better. That's what we're going to do tonight. All right. So speaking of RCI, the first thing I would want to let you know is, oh, I forgot to advance the slides. Sorry about that. Sorry about that, Tom. We have changed the name. You know, residential care is not called residential care anymore. It's now called long-term care. So we had to adjust. We used to be residential RCI, and now we're long-term care initiative. And it still has the goals and aspirations that you see up there. So all the same good stuff, just a different name. Speaking of good stuff, oh, we should remind you that these are the benefits of being a physician in RCI, and all the people who are not physicians know there's lots of benefits as well, particularly having the physicians engaged like this makes a huge difference. You may have been part of the QI funding that would impact your facility. So there's a website down there. You're going to have to write that down because that's impossible to remember. VICSI, I guess it stands for Vic South Island. Yeah, am I right? VIC is Vic, SI South Island dash LTCI.ca. So piles of resources on there, videos of all our previous learnings. What else will we find up there? Videos, notes, schedules, good ideas on how to do care conferences, tools, how to do best practices for care conferences, lots of good stuff, so check it out if you want to learn more about caring for the elderly in residential care. Next important thing to let you know is Fiona Betts couldn't make it tonight. Sudden pressing concern came up, so she won't be part of our agenda, and we're shifting the agenda slightly. So we'll do Mike Allan, and then we're going to do questions. So get all your questions for Mike because he unfortunately has to rush out to another engagement, and then we'll have a break, and then we'll have Robert Seeley, and then we'll have his questions, and then we'll be done for the evening. So get all your questions for Michael right out at the beginning. Interesting. All right. So some of you put some money in a raffle or bought some tickets, and this is your moment to get your tickets out, and we're going to get Megan up here to do something special, like give out prizes. You can use this mic. You're good with the mic?
Yes, hello. So thank you so much for everyone who bought a ticket. As you guys know, all the money is going to go to our place in Adwin House, and you are drawn for one of, well, actually 8 prizes. I did say 7. This is our mystery prize. So if you trust me, I'm going to draw it myself. I'm going to shift it up a little bit. Oh. So the number is 09419885. No way.
Congratulations. What is it? I don't know. It's a, whoa, look at this. It's a... Wow.
Nice.
I wouldn't want to creep you out. There's a whole bunch of things I could say. A little tight. I don't know. Couldn't you got an extra large size? My wife will love this.
Looks good. Nice.
Wow. Now I know how I'll be able to celebrate Christmas every year from here on in.
That doesn't get you in the Christmas spirit. I don't know what will.
Well, maybe a couple of, beers. I'm from Alberta. Mike. So we're doing this fundraiser tonight, and they're raising money for our place, and all the donations that you guys can cough up would be most welcome. Oh, buy your tickets. Isn't it too late? Because, I've won.
Oh yeah, it's not too late, Dr. Nickel.
Oh, all right. So buy tickets. There's lots more prizes. Thanks, everybody.
The break and after. And a bonus, if you win, you get to shake Dr. Nickel's hand as well. So.
We keep the money, though. Awesome. And I forgot to show you what the lovely website looks like, so there it is. On to the regular presentation, what you've all been waiting for. Dr. Mike Allan is the Director of Program and Practice Support at the College of Family Physicians of Canada, a professor at the Department of Family Medicine of the University of Alberta. He's been in practice for 20 years, given over 300 invited presentations, published over 100 articles. He contributes to a regular evidence-based update called Tools in Practice. Tools in Practice fans? Oh, yeah. I love it. Come on. Yeah. He's just a little nervous about putting his hand up. All right. I'm a fan. And also, of course, publishes in Canadian Family Medicine many times. Canadian Family Physician many times. He also co-presents a weekly medical podcast called The Best Science Medicine Podcast, which you can get on iTunes. So go there and wherever your podcasts are available. Please welcome Michael Allan. Come on in. Do we need to switch presentations? I think so. You need to do some buttons? I'll let you do that. Test. Try one of the other ones, or? Okay, I will get started while we sort out the last little bit. I'm Mike Allan. I'm a family doctor, and as you know, I do kind of knowledge translation and that kind of thing, as well as practice. So what I've titled this talk is Sorting Out Dubious Claims About High-Level Evidence. And that's a picture from the guideline itself that's in Canadian Family Physician. That's freely accessible if you'd like. Here's my conflicts of interest. So I get paid, so you probably want to know who I get paid by. I get paid by the College of Family Physicians of Canada. I also get paid by the University of Alberta, although that's because I now live in BC, that's starting to fade away.
and then I do locums on Salt Spring Island where I live now. I've taken grants and speaking fees and honorarium from a whole bunch of different sources, but never from industry. The last thing I took from industry was a drug dinner in 1998. And you can see I've done, but we do a lot of different things like randomized control trials and things like that. I'm part of a group called PEER, which actually derives from evidence-based medicine. Evidence-based medicine is not just about research, it's also about putting it into practice with patients and looking at your experience, taking it into account with your experience. That alone, that acronym spells P. So we didn't want that as our acronym, so we added the research piece because we do that as well. Okay.
We're going to switch you over after that great joke.
Okay.
Great. In the pocket where it works.
Awesome. Great. Okay, so when I, oh wow, that's loud. When I present on this, can we turn it down okay? Yeah, great. Okay, when I present on this, people get edgy, and I'm not quite sure why, because I don't have those feelings about cannabis either way, but I know that when I presented, people have used my presentation as reasons to speak against cannabis and as reasons to speak for. Most of them aren't happy either way, though, with what I say. There are people with very strong opinions. This is Jeff Sessions, who no longer works for the Trump government, but he was stated as saying that anyone who smokes marijuana is bad or uses marijuana. And then on the other side, there's guys like this who say that it cures everything and is good for everything. Now, most people, actually, when I give these talks, are kind of like this. They are not deeply passionate one way or the other about cannabis or cannabinoid products, but some people are very passionate, and when I speak on it, they often have this kind of reaction. And what I found is that for that select few, they don't really care what I say. They kind of, it falls back to Simon and Garfunkel, and that is, you hear what you want to hear, and you disregard the rest. So I'm here to tell you that I don't really care about cannabis. When I look at the evidence, I've done guidelines on osteoporosis, prostate cancer, lipids. So cannabis was just something that family doctors were indicating at the time across the country that they were frustrated, that they didn't really know what to do, but were getting a lot of requests for it. And so we decided we would try and help with that. That's really what it comes down to. And whether it showed something good or bad, I think with all of us, we hope that the evidence is really good for something out there so we can help our patients. That's what we signed up for. So let's first talk about what we're going to talk about. We're going to talk about medical cannabinoids, but when we do, we talk about two separate things. There's the manufactured cannabinoids, and that's things like capsules and sprays and that kind of stuff. And then there's medical marijuana or medical cannabis. Marijuana, for some, is deemed a derogatory term, so we'll try and use cannabis more. But it's the dried cannabis products and oils. Now, interestingly, although we'll talk about them, and I know most of you are here about the actual floral product and the leaves, the fact is this is where the vast majority of the research is. There's not great research, period, but it is almost all the pharmaceutical derived. Okay. And I'll tell you when it's different. Now, this is U.S. data. It's actually, and now particularly, it's quite a bit higher in Canada, but marijuana use is about 7% of the population over 30 days and 35% lifetime. In Canada, before legalization, it was 50% lifetime, just to give you some context. When people use cannabis, 11% of them say, and that's when it's not legalized, 11% of them say, I'm doing it for medical reasons only. And then another 36% say there's medical and recreational reasons. And so if you add those up, that's almost 50% of all users are thinking they're getting some kind of medical use out of the product. Okay? And when you look at medical cannabis, what you find is that 58 to 84% of surveys find that the number one reason to use it is pain. So we're going to spend more time on pain because that is the number one reason that family doctors see requests for it, or that you will. You will think about other ways that it can be used, or there's lots of other ways that it's promoted for use, but the vast majority is in pain of our requests. You'll see statistics all the time that say 70% of cannabis users feel that it works. And in fact, there was a recent study not too long ago that said 90% say it works. But it's important to understand what that research is. So I'll explain it to you in another way. Imagine you went to Starbucks, and you went there every single day, and you sat in the Starbucks and watched people come in, and you saw one person come in and get a latte. And with every latte, they got a pump of vanilla. And every single day for the next month, they came in and got that exact same order. If I went up afterwards and said to them, hey, do you like a latte with a pump of vanilla? Would you be surprised if he said yes? So this is the exact same way this research is run. It looks at people who are using cannabis and continue to use it, and then it asks them if they think it's working for them. So think about that. Of course it's going to show that it's working. So that's why we can't rely on that level of data, and that's the vast majority of the research quality.
You sound better without the mic, so I'm going to try switching mics.
Okay.
You sound like an old man.
Okay. I am an old man. My children say that all the time. Dad, you're old.
Hopefully that's not so crackly.
Okay, good. It still sounds. I've got a powerful voice.
I don't have gain control, so that's the best I could do. Okay, keep going. Thank you.
All right. Okay, so let's move on to the next piece, and that is that 15 to 20% of all pain patients and MS patients use cannabis. It's important for us to remember whether they've asked for it from us or not. I wonder if is that better? That is better, right? Yeah, okay. All right. So there we are. Now, what I wanted to talk about is what was happening in Canada. And I tried to update this, but actually as soon as cannabis became legal, the government of Canada stopped caring about medical cannabis. So they aren't doing any statistics on what's happening anymore, interestingly enough. So let's talk about what we do have. So up to 2017, this was the growth of authorization of medical cannabinoids. I had a person ask me for an interview back in 2018, and they said, are you concerned that cannabis use may double over 5 years? At that point, it was tripling every year. So I said, no, I'm not concerned that it's going to double in 3 years. If you were to forecast, it would be triple next year. So we looked at the data, and in 2018, it didn't triple at all. It started to slow down because we were maximizing that market, and people were getting ready for legal cannabis. So, but the question is, which province is the highest request for authorization or gets the most authorization for medical cannabinoids? Everybody says BC, but it's actually Alberta. Alberta is by far the dominant. It has 1/3 of all the requests in Canada. And so why that is, we're not quite sure, but it is important to understand that was the province that I was in, and so we were seeing it quite a bit. Jason Kenney's the reason. I'm being taped, so I'm not going to comment. These are just some of the uses that cannabis is promoted to fix. Like you can see there's a lot of things there. It fixes everything. As you know, it might contribute to things like schizophrenia and psychosis, and yet it's also marked as a potential treatment for it. And this isn't by any stretch an exhaustive list. This is just one when I did a quick search. Okay, so let's talk about the limits of where we are with research. Now, when I approach this topic of what we should be authorizing, in a sense, prescribing, if this had stayed a product that was truly a kind of naturopathic product or that kind of thing, we wouldn't have been involved and we wouldn't be necessarily having this conversation. But we are involved and we're to authorize it. And so I looked at the evidence with the same kind of viewpoint I have when I've been on the Expert Drug Advisory Committee or what the Therapeutics Product Directorate, that's Canada's FDA, would do. They would look for high-quality randomized control trials of a product to see if it actually provides benefit for patients. So that's the criteria that I set, and that is going to set us up for trouble. Because I'll just go through a couple examples. You've probably heard it's good for glaucoma. There was only one RCT of that, and it had 6 people and found no effect. Okay. And in anxiety, there's actually 2 RCTs. One RCT, it's not mentioned here because we only found it just recently. It was buried, but it was 10 patients followed for 2 hours. This RCT was a single day, and what they did is they had people take it with CBD in this case, followed these 24 people, and it was for the study was quoted as proving that it works for anxiety, but the actual anxiety was measured by a visual analog scale, so none of the formal usual measures, and it was actually done on asking them to give presentations, simulated presentations to each other. That was the way they were supposed to be anxious. It wasn't treating general anxiety disorder or anything that we see. So that's the totality of anxiety literature. For IBS, it was one randomized control trial of 36 patients given dronabinol, and it actually just looked at how fast they went poop. I mean, it looked at transit times. It had nothing to do with pain scores or anything like that. So, and it was 2 whole days. I guess that's the time it takes. Depression, there are no RCTs at all, just case reports. So we're kind of left challenged, but I don't want to leave you with the impression that because the evidence base is poor, this thing doesn't work, because there actually is a really good evidence base for CBD and THC products, and it's actually in CBD in seizures, cannabidiol. And this is 3 large randomized control trials, and this kind of blows out of the water all our belief that this research can't be done or can't be done well, because they did an excellent job of these 3 trials, and if you wonder, they're in the New England Journal, and the Lancet. Okay? So these are big, good trials that went a long time. So the first one is of, of Dravet syndrome in kids, and these are seizure-resistant kids, so they're continuing to have seizures, and they're on lots of different medicines. And you can see here that their seizures went from 12 to 15 per month on average down to 6 in the treatment arm versus 14 in the placebo arm. Okay? You don't need stats on that to know that that's working. And the next one was a 50% reduction in frequency, and I'll tell you why you want both later. 2 different outcomes, and you can see that that one looks quite favorable as well, although it didn't quite reach statistical significance. CBD's talked about the fact that it's generally harmless, and the research shows that it's definitely not. And these kids, a lot of things happened. They were more tired, they had more GI distress, and an important thing, a number of them that were given very high doses had liver function test elevation, quite dramatic, and some had to be pulled. So these are the 2 other studies in Lennox-Gastaut, and you can see they were also very, very effective. So I don't want you to go away thinking that I'm saying that none of this stuff works at all, because that's absolutely not true. We have really great research, and we can show that it does work. It's just the areas we're going to care about today, there's going to be a vacuum or very little. But let's go and find out what's there. All right, positive data. It's not something that we use regularly. That would be pediatric neurologists that would really be caring about that data. But it is a signal for us that there is an active component in there that really does work. Okay? Now, we got to frame our thinking because things get a bit muddy. And I like this picture. Does anyone know where this is from? This is the U.S. Someone said this is from the U.S. That's exactly right. This is the Redneck Olympics in the U.S. South. Okay, this is the belly flop competition into mud. So I don't know. I think he's doing pretty well. I'm not going to give him a 10 because I'm the Canadian judge. So there's 2 primary things that I think you need to know that should color the way you think about this research as we go through. And the first is, and this isn't the only product that you can't really blind, but the first thing is you can't blind for this product. So other drugs that we try to do randomized control trials with blinding, you can't blind. So for example, in Orlistat, the drug Orlistat, many of you will know that. That's a drug that's supposed to help reduce weight, but it actually almost constantly causes diarrhea, and certainly does if you eat any fats. And so when they ask people in Orlistat studies, they all know when they got Orlistat because they pooped their pants. And that's all there is to it. And so they know that they do. And certain other drugs you can't blind for because of their effects or adverse events. This is an example of that. And I'll show you the evidence around it. It's quite fascinating. The first study had actually 6 different intervals in it. And at one point you got a cigarette with 0% THC in it. Then you got one with 4.5, and then you got one with 9. And then you cycled through again. But it would be random. So you might get 4.5, then placebo, then 9, then placebo, then 9, and then 4.5. It was random. In that study, not only could people pick out when they were on cannabis or not, they could pick out the dose they were getting. The chances of getting all 6 intervals right and saying, I know exactly what I got each time, is just under 2%. 57% of them could guess exactly what they got each time. It's remarkable how strong this unblinding is. And if you think it's just the patients who are unblinded, we'll talk about why that is a little bit more. Not only are patients unblinded, but their caregivers are completely unblinded. In a study of dronabinol, 85% of nurses could point and go, that person's high, that person's not, that person's high. So no one is blinded in these studies, or virtually no one. So I think it's very admirable that they try and blind, and that's the right way to do things, but just recognize that that sets up a bias of perhaps around 17% increased chance of finding a benefit falsely. Because you're measuring things here. They're not like the seizures. The seizures actually are witnessed seizures. This is how much do you feel better or worse, right? So it's self-rated, and you know you're on product or not. Okay, the next thing is inclusion criteria. So most of these studies include, particularly the ones where it's actually cannabis and not the pharmaceutical-derived cannabinoid. In those, they generally enroll patients who have used the product before. So if you were someone who used cannabis and you're someone who's unfortunate enough to get a terrible adverse event where you feel very unstable and anxious and that kind of thing, and I said, would you be in a trial of cannabis? Would you agree? No. So what we're picking here are those who can tolerate cannabis. How does that translate to how we interpret the data? That means that when you look at the adverse events, that's the absolute best they can be, because we've weeded out all of the people who could potentially have an adverse event and selected those who shouldn't have an adverse event. Okay? So it's just really important to understand the research when you actually start to look at it. Okay. This is pain, and I love this pain scale. You can see it at the bottom. There's the guy who's got no hurt, then a boo-boo, then getting run over by a car is apparently 4. I would say that's more, but that's you can see the very last one is getting eaten alive by a grizzly. That's bad. And there is a movie with Leonardo in it that you can watch if you doubt that that is 10 out of 10. Okay, so let's talk about pain scales, and we have to understand what we're looking for with pain scales. In a perfect world, you'd get both things, which I'm going to show you now, and I will show you the data for that. But if you have to pick one, it's actually how many people really got better. But let's look at the pain scale. So when we look at the data for cannabinoids, this is particularly in neuropathic pain, most patients start out somewhere around a 6 out of 10 pain. That's where they say they are. And then when you give them a placebo and you follow them for a while, and it's not just the sugar pill you're giving them, because you're giving them time. And we know that our conditions fluctuate over time, and so when they enroll in a trial, they're generally at their worst, because that's why they're in the trial. And so then they'll naturally get better. And just seeing us, seeing caregivers helps people out. So it's not just a sugar pill when you think about placebo, it's more than that. But that alone gets you about 1. So it moves you from about 6 to a 5. The cannabinoids will move you another half point over that. So what does that actually look like? Well, if we fill that in, this is what it looks like. So placebo will move you from 6 to a 5, and a cannabinoid will move you from a 6 to a 4.5. Okay? So if you're like me, you probably look at that and you go, that isn't very impressive. Okay? But this is true of most of our interventions. Before you lose entire faith, this is true of a lot of our interventions. NSAIDs, even in their best in acute pain, it only adds about 1.2. That's all on top of placebo. So just keep that in context. And chronic pain medicines aren't dynamite. We'll talk about how many people actually get better now. And to do that, we need to understand. So imagine in a clinical trial, you have people with an average pain of 6, and it ranges somewhere from 4.5 to 7.5. And then what you do is you actually want to follow them and give them these interventions. And so we want to know how many actually got 30% better, because we know in pain studies in the past that that's when patients say, yeah, I actually feel better and I can do more now. Okay? So we want to know how many get into this kind of 30% better range, and that's called a clinically meaningful benefit. Okay. So that means we have to find out who will get to 4. So if we look at placebo, remember it moved 1, so everybody kind of moves 1. If we, in a perfect world, that's what it would look like. And the drug would look like this. We want to know how many are in now that clinically meaningful range. And in placebo, it's about 30, and in drug, it's about 40. And when I say drug, I mean any of the cannabinoid products, or actually any intervention this model works for any of our interventions, any of our drug interventions. It also works for non-drug interventions like exercise. You want to know how many actually get better, okay? Because that's what we can talk to patients about. And so when you look at this, I chose that 40 and 30 because if you had to guess, that's kind of the numbers you're looking at. Whether you look at whatever type of pain across the board here, when you're looking at palliative, it's about a number needed to treat, not quite as good as 10, but it's around a 7 to 10% benefit. You'll see one that kind of sticks out looking better than the others, and that's this guy, the smoked neuropathic pain. And so you might say to yourself, oh, maybe smoking it is better than the pills. But I'm going to show you that data, and we're going to examine carefully whether it matters if it's smoked cannabis, other agents, or what else might be driving that number. Okay, so does size matter? So this is a question that we bring up in clinical trials because size, bigger trials, longer trials, are markers of quality in trials. And so we're kind of saying, does it matter if it's a good quality study? Okay, this is the Metagraph. This is the systematic review we did in Metagraph. And when you look at the data, what you'll see is in studies that had less than 150 patients, the relative risk of getting benefit, or the relative benefit, was about 56% on top of baseline. So that means 50% more patients felt better, which is good, relative 50%. So if you started out at 40, that means 60% are feeling better. However, if you look at large trials, no one really benefited. No one really benefited. And so what that means is when we look at this data in a more comprehensive way, inhaled and versus the biggest other group was the buccal spray or buccal spray, and that was nabiximols. And when you compare them, there was really no statistical difference. What all of the answers were being driven by, actually there, was that the inhaled were all small and short studies. So small and short studies meant bigger benefit. Not that the inhaled were, and we'll talk a little bit more about what does that mean to be small and short in these, but that is the thing that's limiting these trials, is that it leaves us with the question, does it work at all? When you look at the totality of evidence, you would guess it does work, as I've just explained to you earlier. It doesn't work great, but it works a little bit. But when you look at these, it does draw into question, is the answer we're getting really valid? Okay? And we don't know. We absolutely don't know. It might be, but it might not be. It just raises the question. Some of you will know that in the guideline, we recommended that in many cases you should try the pharmaceutical cannabinoids. And the reason we did that is because that's where most of the research is, except we were frustrated by the fact that nabiximols are very expensive. Okay? It's a very expensive product. So we looked at nabilone, and you can see nabilone in one study looks like dynamite, a 15-point reduction on a 100-millimeter scale, or that's 1.5 reduction out of 10. That's better than what I showed you for the average. So it looks really good. But you look at the other study, and it looks like dihydrocodeine, which is about double strength of codeine or about similar. That actually looks far better than nabilone. So where are we left with? We're not quite sure, just like the other data. Rheumatologic, we really don't know. Not very much research in that area. For acute pain, what's interesting is there's been 7 studies. 1 found it decreased pain, 1 found it made it worse, and 5 found no effect. So that's really a wash. And we haven't really looked at quality of life or function, so a lot of missing pieces still, sadly. So if you were to guess at the best available data that we have, you would say that medical cannabinoids reduce pain by about 30% or more, which is considered meaningful, for about 1 in every 11 patients. And I'll show you actually what that looks like on an icon array, so out of 100 people who gets benefit. The research is biased, so it's likely exaggerated, but that's true of other things too. It's not just cannabinoids. And there's no clear evidence that one cannabinoid is better than the other. We don't have any of that evidence. Okay? Nausea and vomiting. Okay. My kids taught me this trick, by the way. The absence of nausea and vomiting, and this is nausea and vomiting very specifically of chemotherapy, and if you've been in practice, you may have had patients like I have who've asked for it for nausea and vomiting in pregnancy, which it's a flat-out no research, right? And so because of the potential harms there, in the guideline, there was strong advocacy to actually state strong recommendation against use in that subpopulation, and I still feel that's the right call. But in nausea and vomiting related to chemotherapy, this product is likely effective. And so I do want to just show you some of that data versus placebo in a cannabis-type product or cannabinoid. About 47% will say they're better or get control of their symptoms, and that control of symptoms meant an absence of vomiting. Okay, so they could still have some nausea, but it removed vomiting, and the control was 13%. Number needed to treat there is 3. And you can see patient preference is even higher. So a cynic in the audience would say, well, it's higher because they're feeling high, right? And they're enjoying the product. But that's not necessarily it. You can actually maybe have 10 vomiting episodes a day, go down to 2, fail to meet the criteria for control of symptoms, but still feel way better, right? So you can look at this either way you want, and if you hate cannabis, you're going to look at it, people are using it to get high, and if you're very pro, you're going to say it's just that we set the wrong criteria, okay? And you can see versus neuroleptics, it actually won. So in many oncology-type treatments and chemotherapy treatments, when I had patients, nabilone is mixed in there. This is almost all dronabinol and nabilone research, okay? Just to understand, there's virtually no, I think there might be one inhaled cannabis study in there. The vast majority are pharmaceutical. Some other variables that you want to consider when you're interpreting the evidence, these trials went 1 day. They were all 1 day. And you might say to yourself, what the heck? But if you think about it, it's right after chemotherapy and they get their agent, they get either the placebo or the drug then, and see how it does for that bad day right afterwards. Okay? They're almost all older studies, and that's why they look so good. We now have better agents. None of these were compared to, or very few were compared to something like ondansetron or Zofran, okay? So I'm not saying that these should replace any of those first-order antiemetics, but they have a reasonable place in that triage of treatments. Patient preference is higher, and you can take what you want from that. And medical cannabinoids, that's primarily, like I said to you, from dronabinol and nabilone. So there's your benefit. It's about 47% versus 13. That's a big, big difference in medicine. We often don't get treatments that good. Like there's many treatments in medicine that have number needed to treat somewhere in the, kind of 5 to 10 or more for acute treatments. So this is good. This would be like a PPI has this kind of effect, or sildenafil would be another one that has a high level of effect. Okay, so medical cannabinoids work even versus active agents for nausea and vomiting. Patients like them more than it works, maybe, or it's just like I said, we didn't have the right criteria. Okay, I love this. You can't buy happiness, but you can buy weed, and that's pretty close. So this is spasticity, and this is the third area that actually has relatively robust evidence. For spasticity, I had a patient who I was trying to get cannabinoids for, but she passed away, unfortunately, before we could move to that, but one of her issues was spasticity, sadly. And you can see it's not greatly effective, number needed to treat somewhere between 7 and 10, but still effective, and patients actually felt like it helped more than they changed necessarily on their scale. Not a lot more, but a little more. Okay? And so what's interesting is the effect on a scale of spasticity is almost the exact same as what we saw with pain. You start somewhere around a 6, the placebo gets you about a 1, and the intervention gets you about another half more. Okay? So it's not dramatic, like I said, but it is an improvement. And so I was going to try it. She had pain and spasticity, which would have been good. So they reduced spasticity for about 50% versus about 35% with placebo. All right, adverse events. Now, one of the things we hear all the time is cannabinoids are natural and therefore safe. I just wanted to remind you that there are a lot of things that are natural, and so this is a few of them. Yeah. This is natural. This is natural, and I actually saw that guy hiking with one of my friends from Victoria. This was down in the desert southwest. I've seen one of those from afar, which was more than close enough, and I've never seen that and never want to. Okay, but those are some natural things, and obviously I'm poking fun here, just remembering that if it's natural and it has an effect, how could it not also have adverse events? So that unfortunately comes as a package with all of our products too. So overall, about 60% of people will have an adverse event in placebo. So how does that happen? That's because we report everything, okay? So let's say I was in a clinical trial, and I was registered in that trial today, and I went outside and I tripped. That's an adverse event, right? Let's say I got the flu, which can happen this time of year. That's an adverse event. So you can understand that adverse events accumulate. And that's why we need placebo-controlled trials to separate them. And so you can see here, cannabinoids is higher, obviously, but starting at 60, it's already pretty high. So 81, take that for what it's worth. We're counting everything here. So I would have an adverse event for more hair loss, I think. One of the things we hear all the time is, but it makes you feel good, right? And so that's the euphoria piece. And some people think that that's a bad thing. Some people think it's a good thing. I don't really, I'm quite indifferent. We shouldn't be prescribing for euphoria. That's not a thing that we're prescribing for. But if it does other things and happens to do that, I'm not necessarily enraged by that. But it's important to remember that almost the same number get dysphoria. Okay? So a fair number of people, and those of you, and I'm not saying anyone in this audience did, but they may know someone who smoked cannabis, and they may know people who actually didn't enjoy it at all and had a bad reaction to it. And for those of us who've actually prescribed it to people who haven't used or authorized it for people who haven't used before, some of them come back and they hate it. And that's just the way it goes. And it's like that with the pharmaceutical products we prescribe. I've given Elavil or amitriptyline to patients who love it, think it works great for them. And then I've given it to other people who can't tolerate it at 5 milligrams. And so, and how do I figure that out? My best case of that was same day. This guy came in, huge guy, big weightlifter guy who was having pain. Elavil, 5 milligrams, couldn't tolerate it, tired the whole day. And the same day, a woman came in and asked if we could go higher than 100 because she wasn't feeling anything. She had some relief of her headaches, but that was it. I don't know how that's possible, but that's the way people are. Okay, so this is two things that I think are relevant for as we are treating older patients, because there are adverse events that are concerning in this population, and we saw that somnolence and those reactions with CBD in kids, so it's not that one product is free of all those adverse events. They actually are occurring in populations, and it's important to know about them. And you can see the number needed to harms there are quite high. You can see here, one of the troubles with looking at adverse events from systematic reviews is they pool things they shouldn't pool. Like visual hallucinations is not the same as blurred vision. So I mark that for your attention because it's ridiculous that those two things are together. I would say they're subtly different and much more alarming. But disassociation and psychosis does occur with some of these, but again, that's a very low threshold for that. Okay, I think that there is a concern about psychosis and that kind of thing with these products, but I also think that we set a low threshold for some of these. Okay, and you can see grouped as psychiatric. That isn't really helpful to me either. But anyway, that's the data we have that we can use. Okay. Things to consider that these are, remember, they enrolled frequent users, so we were more reassured by that, and they were shorter durations. So less time to accumulate things like hyperemesis and that kind of stuff, okay? Less time. So versus placebo, many different adverse events ranging from this visual disturbance, whatever that means, to hypotension, which is obviously very concerning in our elderly patients, and to hallucination or paranoia for 1 in 20. 1 in 8 patients given it to up to 1 in 20, so the better is the 1 in 20 number, obviously, but as little as 1 in 8, depending on dosing. And the adverse events here are likely underestimated, if anything. And so we have to make sure that people are getting a benefit when they're on these products, because the harm and the risk is high. So from the Obama campaign, when they go low, we get high. I don't think he said that. And this is the CMAJ, and I think the CMAJ has something called 5 things to know, or 5 points. And their point 2, when they were talking about medical cannabinoids, was probably the most spot on. So I wanted to just draw it to your attention. They said that in many cases, medical cannabinoids are still experimental, like for the treatment of anxiety. We actually don't have research evidence to support them for general anxiety disorder, nothing at all. Most clinical trials use pharmaceutical cannabinoids, not smoked THC. Very important to remember. Back when this was written in 2017, 40% of all strains had 15% or more THC, and by the time I started to look at this, it was 2018, and already it was 58% had 15% or more THC, and at that point, 9% was the highest studied. But I'm going to show you a new study that has used something higher. Okay? And THC, the smoked, is not superior to any of the other methods right now. We just don't know that. Okay, so because this is about the elderly, I thought I'd include a little something about agitation in that. I know you've been talked to about that. I love this picture. So this is a systematic review that focused specifically on the elderly, and it's often, we were going to use it in a recent review we're doing with the college, and I just wanted to point out just a few of the weaknesses that really kind of, this looks very promising to find a systematic review like this, but when you actually look at it, the mean age of this study of older subjects was 47. So that is, I would not consider that elderly. If it is, I'm well into elderly. And then these are kind of rare and stranger disorders like levodopa-induced dyskinesis in Parkinson's disease. That is a very specific subpopulation of patients, and it included 19 of them. Okay, that's it. So I didn't think that one was really useful. This one included 5 patients that were given CO2 inhalation to induce breathlessness. So I don't do that in my practice. So this is the research, people. I'm sorry. So, and this last one has 2 people in it. Randomized control trial with 2 people. That's it. So I don't think, so what we're left with is one randomized control trial, and that was with patients. And I'll show you some of the data around food, trouble with appetite and that kind of thing. Our other treatments are still, I'll sum it up right now, the other treatments we have are still better for decreased appetite than cannabinoids at this point. And there was a drug that we were trying to market, actually was brought to the market in Europe, that was actually derived from cannabinoids that fought appetite. So it was to weight loss, but it actually was causing too many harms, and it was a psychiatric harm, so it was pulled from the market. We never saw it in Canada. This is the Agitation systematic review with 6 RCTs. You'll notice there's one more trial here than 6, and that's because it's a crossover and they double counted it, which is not a big deal. But you'll see if you look at the THC ones, there was no effect there at all on agitation. So that point, the fact that that gray point is dead center middle and all of them look identical means that nothing is happening. Okay? If you look at the ones where it is happening, it really only boils down to one clinical trial. So I wanted to draw your attention to what's happening in that clinical trial. It's this one right here. And what it says, what I'm trying to explain to you is their enrollment criteria was a CMA-I score, which is a research score of agitation, and it was heavily imbalanced between the 2 groups, which means they likely weren't really a randomized trial. They likely put people into groups. So if you use randomization methods like pulling from a hat, flipping a coin, whatever, doctors will cheat that method, and they'll put the patients in groups they want. It's called allocation concealment. And you can see here that in this case, the much higher score was in the cannabinoid group. So why would you put the worst people in one group? And the reason is there's a natural progression to the mean, and if you start further away and you're going to progress to the mean, you're going to progress further. So if you do a pain study and you set a 30% change, you want them as sick as possible because you will get a better benefit in those because they're more likely to get better. So this was a bit of a stacked deck, and it's the only one that really shows benefit. Okay? And they use something called a standard mean difference, which is a statistical measure that has no value for us clinically. Okay, marijuana sent to the Joint Committee. This is our guideline, and it's just the recommendation for the 4 areas that have key, the key or best evidence for them. So they didn't involve pediatric seizure because that's not really a primary care thing. But you can see for neuropathic pain, palliative pain, spasticity, and chemotherapy-induced nausea and vomiting, it can all be considered in those cases. Now, we're doctors, and guidelines are here to offer guidance, not strict rules. So have I ever, as I said to you, I've written a lot of guidelines or been involved in them. Have I ever gone outside my own guidelines? Absolutely, because I'm here to help take care of people. So take this for what it's worth. It's our best course of action for the majority of the patients we see, but not all of them. Okay? And so please don't feel when you read guidelines that you're handcuffed by them, because we shouldn't be. And I write guidelines, and I strongly feel that we shouldn't be handcuffed by them. Okay. Neuropathic pain, what we did is when we saw how it was working and the adverse events, we wanted to get a context because neuropathic pain was the #1 reason to advocate for cannabinoid use. And we wanted to see how does it compare to kind of other interventions for neuropathic pain. So we created this table that's in the guideline, and you can see this is looking at how many patients get a 30% or more benefit. And green is the action of the drug itself or the product. So in amitriptyline, it's about a 25 patients out of 100 will get better because of amitriptyline. 25 or so get better just because they're going to get better anyway, or placebo or what have you, okay? So that's kind of stable across the board. And then when you look at the other things, high-dose opioids, we're looking at a systematic review of osteoarthritis right now, and it's, I'll give you a little heads up, it's going to show that opioids don't work after about 4 to 6 weeks for osteoarthritis. So we'll look at that same, we'll try and tease out that same kind of data when we look again at neuropathic. But right now, they're still not the most effective agent, and they're certainly one with a lot more harms. Venlafaxine and duloxetine. Venlafaxine looks like it's a little bit better. It's probably just the way we have to, when we do this comparative math, it's the way it comes out. I would use duloxetine first if my patient could afford it, or I could get them covered because the evidence is far better for it. Gabapentin or pregabalin, I would pick the cheaper one. They're both about the same. But you can see cannabinoids, when you look at those, these all have a much bigger effect in general than cannabinoids. So cannabinoids, I pointed out to you, have quite a few harms, and they're the least effective of all the agents we have available from the best available evidence. And this is ignoring all that stuff I told you about larger trials not finding a benefit, etc. This is taking all the trials for what they are and trying to give the most positive spin, and they're still likely the least effective of all the agents we have. So it's important to recognize that, and that's why we said you have to try other agents first. And people have said to me, well, you're saying we should try opioids? No, we said 3 agents for neuropathic. That's a TCA of some type, an SNRI of some type, and a gabapentin or gabinoid of some type, okay? So we didn't recommend you go to narcotics at all. It was just, it's just important to recognize that. Last thoughts. I was telling you where people are and how much they smoke. So when you're looking at a maximum of 9%, which is what we were originally recommending, and you take one drag, that's about 100 milligrams, and you can see as you titrate up and you smoke, let's say, a half joint a day, it's 400 milligrams to QID. That's what was recommended originally. Now people are actually using a lot more. They're using up to 27% THC, many 15, and they're smoking up to 5 grams a day or 6 joints. And so you can see they're getting about 20 times the amount of THC that had been studied up to date. Okay? So that's one of our problems right now is when we authorize, it's free access for these patients to interact with the licensed prescriber or licensed producer. So it just gets kind of crazy. It can get kind of crazy. This is just a reminder of what they cost. So Nabilone is $94 to $300. Nabiximols go up to $900, which I think is insane. But cannabis is the same thing. I've had lots of patients complain to me about the cost of dried cannabis. It's a lot more than I thought it was, which shows something about me now. Okay, how many of you have heard people say that THC or CBD is better? Or that kind of thing, right? So I think it's worth looking at what evidence we have right now for the various products. So the background is there are tons of chemicals in cannabis, and you can see here that the first one discovered was cannabinol, and then cannabidiol, and then THC. Okay, so let's talk about what we know about them. What we think is that the THC is more the psychoactive substance, and the cannabidiol is the non-psychoactive one, and that it may dampen some of these effects. Where does that come from? That comes from actual research, but it's small. It's like 6 people. We were randomized. We gave them THC, saw how they got agitated, then gave them some CBD with it, saw if they got agitated, and we PET scanned them. Those are the kind of studies that we have. And the other ones are hair samples. So what they did is they took hair samples and tried to find CBD or THC in your hair, and then looked at how if you had trouble with the law and all sorts of things in the last little while. So there's some pretty kind of iffy stuff. But let's get on to where we have randomized control trials of patients, okay, which I think is very helpful for us. So this is an RCT with 240 terminal cancer patients with weight loss. They compared THC to CBD, or THC, CBD to THC, and there was no difference. And it didn't, versus placebo, it didn't affect appetite either. This is refractory cancer pain. You can see these patients are on a whopping amount of morphine equivalent, 270. That's certainly historic. So, and then when you see what they're looking at is the 30% pain reduction, you can see 38% got there with THC CBD versus 21% with THC alone. So keep that in the back of your mind, that this is the first signal we've had that maybe the combination adds something to THC alone. Because this is like a scant research when we're looking at this. Adverse events weren't significantly different. This is brachial nerve injury. It's a special type of neuropathic pain, and in other research, brachial nerve injury is a bad type of pain, so their baseline pain score is bigger than that 6 that we've seen before. And you can see THC with CBD and THC were both around 1.3 better, and placebo was 0.6 better. So they were about 0.7 better than placebo, but certainly nothing dramatic and nothing different there. This was a super strange study. What they did in this is they had people smoke a mixture of THC and CBD cannabis, and then they had them randomized to each different component and the two components together, or a kind of hemp where there was no THC CBD in it, and they kept doing that to them, and they'd say to them, do you think this is as good as when you smoked THC CBD together? So it's a weird design. There was no scale measurements of pain or anything. They just asked, do you think you got as good pain relief as you did the first time? And so you can see there THC CBD was slightly higher than THC or CBD alone, but nothing was statistically significant. But if you were guessing, you would note that CBD is the lowest of them. Okay? This is the best clinical trial we have comparing the different products, and it compares all three, the combination, each individual one, and placebo. And why is it so good? It's not because it's 3 hours, and it's not because there's only 20 people in it, but they actually did an incredible job of controlling inhalation. So people were, they filled a balloon with a fixed amount, and the patients had to draw off that balloon until it was done. They had to hold their breath a specific time, and they were watched. So they did everything absolutely strictly. They drew blood at an hour, 2 hours, and so on, and they had them do a ton of scores to see what happened to them psychologically, happened to them pain-wise, etc. And you can see it's mostly THC, a combination, mostly CBD, and then placebo. Okay, so what happened? Like I said, it was only 3 hours, so take this for what it's worth. We know, we already learned that the longer the study goes, the less effective the product looks. So if you're going to see a benefit, you're going to see it at 3 hours, because that's the most optimized time right away. It's the same with weight loss. Weight loss is always best in the first kind of 3 to 5 months, and then it starts to disappear. So just remember this is 3 hours. So the numeric rating scale is the same as a visual analog scale, and you can see that THC CBD dropped pain by 2 whole points. Okay, that's not bad. That's not bad at all. THC alone didn't do quite 2 points, but got close. Placebo was a little bit better, and CBD was a little worse than placebo. Okay? So now we have a couple different studies showing that CBD is probably the least effective for pain by itself, but we also have research showing that THC CBD, the addition of CBD, may add a little bit to THC's effectiveness. Okay? And they asked the question, remember I told you we want to see both. How much did it change on a scale, and who got better? And this actually told us both, which I think, again, it's a short, small study, but it did have good data. And 90% got there with THC CBD, 65% with THC, 55% with placebo, and 40% with CBD. So again, CBD looking the least effective. THC had psychedelic effects more commonly, and what was interesting is CBD did seem to suppress some of those effects. No surprise to a lot of us that the high was correlated most strongly with pain reduction. So the more high you felt, the more reduction in your pain. Okay. All right, so the effects are not much over placebo as much as we'd hope, but there still is, and they're associated with a high, but there still is now more evidence about that combination, which was very uncertain before, and I would say now we're getting a glimpse of real evidence that it is actually, the two of them together is a good thing. CBD alone, very uncertain at this time. We could get a huge trial with 350 people in it that's actually going to answer these questions, but right now this is the best we have, and you'd have to guess that it's not very effective by itself. Okay, so what's our bottom line? Most studies were of healthy people when they looked at the kind of psychological effects of them. They didn't really talk about the concentrations or anything, so it's very hard to tease out what was actually happening in that kind of preclinical research. The clinical research, we have 5 RCTs. Only 2 use CBD alone. But when we did, what we can pull out of that is THC with CBD does seem to have potentially some additional benefits. So CBD may also dampen some of the psychological effects. All right, I want to leave you with this. This is a pain tool that we've devised as the peer group with the College of Family Physicians of Alberta and Canada. And so what you can do is you can go on this, it's just called, you can call it the CTOP tool, which is comparing treatment options, but also pain calculator will get you there. And then you can pick options down the side and it'll tell you exactly what % of patients will benefit from the product, how many will not get a 30% pain reduction overall. So you can see with amitriptyline and neuropathic pain, that's going to be about 50%. We'll be adding osteoarthritis in coming up very soon, so probably in January, February, we'll add osteoarthritis in. And it has a lot of different components to it. So it tells you what we mean by meaningful pain reduction, so you can explain that to your patients, going from about a 6 to a 4 pain reduction. It tells you what the most common adverse events are and what their chances of getting them versus placebo is. It tells them what the costs are of the product in general terms and some nuances of how they should take it, like Elavil, you know what amitriptyline should be at night, or in the evening, rather. And then it tells you the actual benefits. So this is a tool we're creating to help discussions with your patients that you can have. And you can see cannabinoids are on there as well. Anyway, that is all. Thank you very much.
For questions. So this room is a bit tricky with questions. You have to push your button to ask a question.
You have to push my buttons to ask a question.
Yeah, of course.
So we'll do this room.
Oh, hi, me. I had a question about the adverse effect slide, the impaired memory. I didn't quite understand the NNT for that one.
Right, so it's a number needed to harm. How many patients need to be treated?
Yeah, impaired memory.
Oh, you want me to go back and look at that? Is that what you're...
Would you mind?
Yeah,
please.
sure.
Thank you.
I'll try and get back there. It's going to take a little bit, but we'll get back there. So what we're looking at is what's been found in research of patients and to a certain extent clinicians as well, is that we're better off when we talk about what your natural frequency or actual rates of something happening with and without treatment are. So that's the way all of this data is presented. Sorry, it takes a little bit longer to go back, but I want to make sure we're there to talk about it. There we go. So what we're, where was impaired memory? There it is. Okay, so yeah, so it was 2% versus 11%. It was studied very infrequently, and so it didn't reach statistical significance, but it would have a p-value somewhere around 0.06 or 7, and so we felt it was still valuable to include the possible number needed to treat there, or number needed to harm. But the rates of events are about 2% chance of that happening with placebo and about 11% chance with cannabinoids. Okay? So that might not be true, though. Remember that, because that's not statistically significant, but that's the best data we could find. Yeah.
Can you say something about whether any evidence exists of the addiction potential of THC?
Yeah, so I'll talk a little bit about that. So as far as prescribing it as a pharmaceutical agent for, as authorizing it, we have almost nothing. I'll be honest with you. Cannabis, as far as substance use goes, is a very interesting thing, and I haven't done a ton of looking at that, but one of the things that really fascinated me was, compared to other products, people can come out and into cannabis use disorder. They can shift out and in of that much easier than other conditions, including nicotine, which is interesting to me. It's harder to, people are more likely to just, where you look at a population and you select those who meet the criteria for cannabis use disorder, look at them, this study looked at them 10 or 15 years later, and only about 50% of them would still, and I'm guessing at these numbers, but it was a considerable drop, had stopped meeting criteria for cannabis use disorder. Might they still have a problem? Yes, but did they have it as severe? No. So it's an interesting thing that way, that people can seem to kind of drift out of it over time. I'm not saying it's safe. Don't get me wrong. I'm just saying that that's what the research shows. Those are cohort studies, too.
Another question. At the back.
What, in your opinion, are the main reasons for the lack of high-quality research?
Yeah, so that's a great question, and there's a whole bunch of reasons. If you ask around why that might be, nobody actually knows. One of the main reasons is the driver of research in a lot of the world is the U.S. And they invest a lot of money in research, and they get a lot of money, and this is a very strictly prohibited substance in the U.S. in many states for a long time. And by the time it got legalized, the cat was out of the bag. Just like in Canada, I feel personally we should have taken some of the profits that were, but there should have been a small tithe, so we could have put money aside to actually do quality research that was publicly funded. But in the U.S., there was a lot of restrictions. I remember hearing someone talk who had tried to do an RCT of cannabis, and he said the nightmare that he had to go through to get access to cannabis to actually do the randomized control trial was too much. And he was afraid also his reputation would be tagged as you know, if you've gone to the States and talked to your U.S. colleagues, their opioid prescribing is on a heavy microscope, and they can get into trouble with that when they're actually, I don't think, really doing anything wrong. But so there's a nervousness that I think reflects the absence, somewhat reflects the absence of research. I think there's also among researchers, right? So there are researchers, I'm not going to name them, but some people have a negative view of them because they've done research in cannabis. You're pushing weed and all of that stuff. And if you do research in an area, you're almost, and you focus on that area, you're almost inevitably going to grow attached to that area, okay? Because you can imagine whatever career you guys have in this room, you've done it a lot of your lives, and you believe in it. You have to believe in it, or else you wouldn't get up in the morning. And so the researchers are the same thing, and then they get tagged as people who are, and then especially if they join up with one of the licensed producers. It's a catch-22. And so I've had licensed producers ask me, would you be our research guy? And it's not really my thing. I don't want to do that because I'm more interested in general practice, period. I don't want to focus in on an area anyway. But so they're stuck a bit is what I'm trying to say. It's not all blame game at all. It's just the nature of the business here. And my biggest concern about it is our enthusiasm, or some members of us, our enthusiasm for that exceeds our knowledge of it. And we can talk around it, but the absence of quality evidence that we would use to bring to bear on decision-making about any other pharmaceutical product, we would ask the same thing of this, and yet there's almost a discomfort or a misgiving about doing that. So I wish I had a better answer for you, but there's lots of reasons, but probably it's a combination, like everything. Yeah.
There's a question here, and then we're going to go to the other room, so other room, get ready if you have some questions.
I'm just wondering if you read Dr. Hermish's research on dementia controlled through cannabis.
No, I haven't read that. I've looked at dementia research out there, so I have a presentation on the treatment of memory loss and dementia, a little bit on agitation.
Yeah, because their research was specifically designed for 65 and older.
Yeah, so so you have to remember, I look at randomized control trials. So if they did a cohort study or that was unrandomized, I wouldn't look at it, because that pile of research is bigger than this room, right? And it's easy to do, and I explained a little bit about how you can cheat that research. So if he has a randomized control trial, please pass it my way. I'd love to see it. But I looked again before this for 2 more hours trying to find a clinical trial, and someone actually sent me a systematic review, which was helpful. Yeah. If you have the trial or other things that I can go on, I'm happy. It's easy to reach me, Allan@cfpc.ca, or through the guideline.
All right, over to the other room. We want you to ask a question too, so push your button. Push your button, ask a question. Come on, guys, you got some questions? Or were you asleep over there? We can see you because we know you're awake.
My picture that I showed at the beginning of the people sleeping was actually the other room.
Ah, I see. All right, just wave to make sure you know you are actually awake. Give me a little wave. Yeah, all right, they're awake. No questions. Okay, back to this room.
There was someone over here.
I had a
Megan,
question.
So we'll do Rainder Green.
Hi.
And then Megan will have to get herself a mic. Someone can help her in the back.
Yeah, go ahead.
Hi. Just my daughter was recently diagnosed with cannabinoid hyperemesis syndrome.
Yeah.
And it took a long time to get to that. I mean, she's probably 12 years in and out of hospital. But is that on the rise now? Do you see that more?
So it's interesting. We see that a lot more in the literature, but it's not reported in a way that you can estimate numbers. It's unfortunate. And when you bring that up, like many of us probably now, as we become more aware of it, I had a young man who was vomiting in my first years of practice, and now in retrospect, I'm 90% sure he had hyperemesis due to cannabis, and I missed it entirely, and the GI guy missed it. And I, you know, like all of medicine, it's a practice. I learned from that, and I caught it. I caught a couple cases later, but I actually see it more commonly. Interestingly, when I bring it up with my patients that I've tried to, they've all denied that there's any association, and only one guy even agreed to go look it up. Yeah, it's a very hard thing because it's a belief system, right? And remember, we're the same. None of us are different. We blame our patients and all of that, or don't blame them, but we get frustrated by them. But we're the same. We believe a certain thing, and it's very hard for us to let go of that strong belief once it's been established. And so if you get joy from it, and it's been getting joy from it for years, and then someone tells you that it's hurting you, it's really hard to accept. And so I've certainly found that. Have other people found that with their patients, that it's hard to kind of get them? Have you guys? Does anyone else here have patients with hyperemesis due to cannabis? Yeah. Has anyone had trouble convincing them? Have you had trouble? Yeah. And have you had trouble with convincing them? Yeah. It's really unfortunate. And you guys know the bath thing, right? If they go into a warm bath, it makes them better. And yeah. Yeah, because you feel way better. Yeah, it's fascinating. Well, just go here first and then. Yeah.
So I guess I assume that people are using it because they're getting high and they're zoning out. But if there's no evidence for it making people feel better, why are all these people using so much of it all the time?
I think there's, so you have to remember some of these things. So if you looked at the neuropathic pain studies that were done of smoked cannabis, much more of them report benefit, especially because they could sort out when they were on it. But if you look at ones that people they didn't know what they were getting and they hadn't been regular users, it's a different story. I would say that for my history, and I'm a family doctor who has a part-time practice at best because of all my other jobs, but out of the people that I've authorized, it's been people requesting it from me. And I mean, I know you guys have your crazy stories. My favorite is a guy wanted me to authorize smoked cannabis for asthma. That was my favorite. But so we get tons of requests, and I think it probably does help them with their symptoms. But is it? One of my patients said it to me best. He had got access to cannabis somewhere else, and I asked him how it was going, and he said, you know, I'm still, I think, in the exact same amount of pain. I just don't care about it anymore. And I don't know, is that a bad thing? I don't know, right? And so do we have the right tools to measure that right now? Maybe not. Maybe when we see these scale changes, it's not picking up that. But I think it's like every product. Some people it works very well for, and others it doesn't work at all for, and some it only barely works. And I know you guys see patients with dementia, so you know that with some of the drugs that we give. They don't work in some people at all. Yeah. Yeah. Okay.
Give it a try.
Hello, Bueller. Hey, other room.
Yeah.
Excited about your question. Oh, hey, Allan, we're getting it.
Yeah, sleep chamber here. Any research that you're aware of for use in irritable bowel syndrome? I was speaking with one of... Okay, go ahead.
You might have missed that right at the beginning. There's only one trial. It has 36 patients, and it didn't look at any symptoms. It just looked at how fast between a meal and their back end, like how quickly it was transiting. That was all they looked at. So it's unfortunate, but that's what we have right now.
Time for one more question, and then we'll give him a rousing round of applause. Anything in the other room? 160, going once, going twice. Someone here. Last question.
Yeah.
Push your button.
I did. Is it not? I don't know. Okay. So I was just listening to Dr. Brian Goldman's blog about the non-opioid pain relievers misuse of gabapentin, and that there's a greater of it maybe showing that it's more dangerous than we have been thinking. Do you see that factoring in this that you're doing here?
Yeah. So gabapentinoids. So they're what the person's referring to is the fact that there is research now that they can be abused. So many products now that I never imagined, Benadryl, all sorts of things have been abused. But there's certainly one, and I have a good colleague who works in the prisons, and she says one of the tricks is to smash it and snort it as fast as you get it. And so that's the way to get the best out of gabapentin. So, but do I see that entering into the equation more? I think so, but not a ton. Like I don't see that. The biggest problems that I see with the gabapentins is that they've been pushed to very high doses, and most people can't tolerate that. I haven't had a patient get above 300 TID of gabapentin, and I haven't been unfortunate enough to have a patient get dependent on it that I know of. No one's come asking for more or any of that stuff from me. It's tricky. This is a terrible thing. You know, the pain problem that we and our patients have. How do we adequately control their pain? And I'm laughing because one of the things we see is exercise for OA is probably the most effective, and we're going to say that, but we know that people won't do it, most of them, but it is the most effective. And so how do we find that product or that intervention that's right for the patient, but also isn't a high risk, right? That's where exercise is so good. But
just on that topic, can you tell me how much the pain scale budges with opioids? So we've got the 1.5 for many things, but how about opioids?
Yeah, so it's a great question. So if you were to look at opioids in this kind of thing, so they move about a half, early on, they move about a half to 1. So if more than placebo, yeah. So they're certainly not dramatic. They're not what you would think. And if you look at clinical trials, they're too short to actually look at substance use. So like developing a substance use disorder, the biggest problem with opioids is tolerance. People can't tolerate them. So they have a really high dropout rate, which then makes the drug look better because they do an analysis where they extract all the people who weren't doing well, right? So it makes these look better. So it's very tricky, a lot of this work that's been done. And so you have to kind of, and that's why the team I have is so awesome. We get to spend time going through all of this.
All right. That was amazing. Don't you know so much more? Big round of applause. Thank you. Can you stick around for 10 minutes?
Yeah.
For individual questions? Individual questions, come on up. Everyone else, go buy a raffle ticket and have a drink of water and maybe some chocolate if you can find some. And come back. I will round you up in 10 minutes.
Thanks for having me. This is where I have a nostalgia thing for me. This is where I did my first degree, right? So I come back and be here.
We're happy to have you.
Yeah, I know. It's awesome. Thank you. So I need my glasses, which are here. Okay, let's look. Okay, I'll be just going to look at one more question. I get these questions all the time. It's going to be an awesome
Yeah, yeah.
I listen to it all the time. I thought
Got the mic. Test, 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 test. I'm going to have a big conversation really loudly, but it's not crackly. Maybe I just had a really big voice. Yeah, even when I'm really close and talking really loud, although I don't want to go, yeah, you can make it do it. He pulled it away and it got better, but it never went away entirely. Can you just go check the back for me? Just walk back there and, yeah, back there.
I just was wondering if you had heard of that, if there's people that almost like overdose on it or they intensify their pain to the point where even now the withdrawal from it, they find a comfort zone or happy place again. Yeah.
So if I'm having a passionate talk about everything that I love, it's still a little bit crackly. So I just have to dial it down. Sorry, I'm testing. If I pull the mic away, it does get, no. Just have to make it quieter. Talking very loudly and it just gets crackly. No? Better, but still crackly. Okay, I'm going to do one other thing. I'm going to put it on. Are you? I'm not high. This is 0 dBs. Testing, 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 nothing. Testing, 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 testing.
So, and I don't think that's really either.
All right.
They're not.
Okay. It's just sensitive.
What we need now is good quality air, just like you suggested.
Oh yeah, there's a light. Everyone. Yeah. Yeah.
Test.
Test, 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 test.
people are in here, yeah?
All right, perfect. Oh, yeah. Let me go grab you one, okay? I'll be right back.
Absolutely. If you found a fan, let's turn it on.
Hello, everyone. Please take a seat and pull out your tickets. Hello, everyone. How was the first part? Pretty good. How was the food? Nice. Did anyone get the hot chocolate? Oh, sorry for you. I think that was the creamiest hot chocolate I've ever had. All right, we're going to do 3 of the draws right now. We're going to do 3 of the draws right now. So there are 7 gifts on the table in front of us, or on your screen if you're in the other room. The grand prize is 2 tickets to the Christmas season at Bouchard Gardens. Woo! That is the grand prize. So that's the person whose name gets drawn at the very end of this next talk will get that one. So if your name is drawn, you don't get to pick that one, I'm sorry, at this time. So something to look forward to. Otherwise, we have a local coffee and tea pack. The coffee is from Langley, tea is from Victoria. Ooh. We got some local olive oil and balsamic, or not balsamic, it's like a rosé vinaigrette. Anyways, very good. We have some local honey from, yep, perfect, work it. Next, we have a jelly jam combo with crackers and chocolate. These can go towards you making a cheese board or a charcuterie board, your little starter kit. Nice. Next, we have a mug and chocolate. This mug is from Victoria as well. It's called Misty Mountain. And last, we have a zero-waste starter kit with your own beeswax covers and bag. So one of these could be yours. So everyone get your tickets out, and we are about to draw. Would you please select the first winner? All right, well, save some for me if it is. 01338-244.
Someone from the other room?
01338-244. Just going to wait in here. Oh, push your button if you won. Or tell the person in front of you. 8244, the last numbers. Draw again. Zero 9419798. 09. Hello. Winner. All right, winner. Woo! Come into this room and you get to select your prize. It's select. I did promise it. Oh, they're running.
They're ringing.
Yay!
Woo!
We trust you. Rachel, we trust you. Tea?
All you're choosing, we'll select another one. Yeah. All right.
Just grab it.
All right, next number, 01338-001. What? Did you win it? Okay, 01338-001. Nice. She bought her ticket at the very last minute, too. Oh, the olive oil and the balsamic. All right, last one for this drawing. 01338-188. Yeah, I know. Sorry, I'll try better next time. 01338-188. No, it wasn't her. Okay. All right. Yeah? Or is anyone coming? No. Draw again? 09419856.
Round of applause for our lovely winners and our helpers. Dr. Robert Seeley will be our next presenter. He's been involved in clinical research in aspects of medical cannabis since 2001. He's involved in 4 groups that do this work: Physicians for Medical Cannabis, Canadian Consortium for the Investigations of Cannabinoids, International Cannabinoid Research Society, and International Association for Cannabis as Medicine. Numerous general practitioners and specialists have referred over 1,000 patients to Dr. Seeley for consideration of medical cannabis management in conditions that have not responded to standard therapy. Seeing a void in the research regarding the use of medical cannabis, Dr. Seeley has traveled the world as one of the few instructors in this field. With legalization of recreational marijuana across Canada, he also is invited to many keynotes and offers his opinion on the potential benefits and implications of this big decision for Canada. Please welcome Robert Seeley.
Thank you. Thanks for sticking around. I know it's getting late, and I know you really were here just for the final draw prize, but I'll try and add something to tonight's entertainment. My talk's going to be a little bit different than the first hour, just in case you're wondering. And, it's nice to see Jamaica right in the front row up front. Yeah, this is going to be, makes me feel comfortable right away what I'm about to talk about.
Is it this one or that one?
I'll use this one. Yeah.
Keep in mind you're only sometimes.
Okay, so where am I on the screen? I like to move, so I can't stop moving.
This is your playing
area. This is my playing area?
Yeah.
Okay, good. Yeah, no, the first hour was very, very interesting, and I wish Dr. Allan could stick around. He is absolutely true in the fact that we have lousy studies on medical cannabis, right? Those, you just saw it, randomized clinical trials. There's very, very poor studies. So to make decisions and make conclusions based on very poor studies, I think leads us down a pretty bad path. But he's absolutely true. That's all we've got to deal with. Otherwise, we deal with observational studies. I don't like to use the term anecdotal because everybody thinks of it as very awful. It's just people telling stories, right? I call them N of ones or individual case reports. And there was a really good question is, why don't we have good randomized clinical trials? I think there's a lot of reasons why we don't have them. First of all, think about it. It's a plant, right? It's a weed, actually. You can't patent it. So big pharma usually puts money into research. Who's going to put money into this plant? You're going to lose. You know how much it is to even launch a single drug these days in the market? Say a high blood pressure pill or cholesterol pill. When you think about the marketing, when you think about the research and the development, and how many clinical trials that they have to go through to get it to market, it's about $5 billion for a single ingredient drug these days. When you think about cannabis plant, you heard it. It has almost 500 parts to it. So how do you tease out every individual component? That's a big problem. If we wait for enough randomized clinical trials, we'll never use this. I'll tell you that right now. Because you just can't do enough trials to satisfy that there's enough evidence. So we have to rely on the observational studies and surveys, etc. This is the most studied plant that's ever been done. This has been around for thousands of years. There's lots and lots of journal articles, but they're not all randomized clinical trials. So that just to put that into perspective, okay? So first of all, here's my disclosure. I have done talks for a number of licensed producers and also developed educational content for places like Aurora, Spectrum Therapeutics, and Tilray. Now, let's talk about cannabis, the history of cannabis. It's been around, like I said, for thousands of years in Chinese medicine, etc. Did you know in the early 1900s, it actually made up 28% of all prescription medications? So Big Pharma knew that cannabis was an active ingredient that they should incorporate. Okay, Eli Lilly, Park Davis, all these ones. The trouble was they didn't know how it worked. This is a cough syrup from the 1880s, okay? It had cannabis in it, but it also had morphine, alcohol, chloroform, and a few other skillfully combined ingredients, right? So it was very effective. I mean, it might have been the last night of coughing, but it was effective, right? So this is what we dealt with in the early, 1800s, late 1800s, 1900s. And then along came, a legalization of cannabis. It wasn't until the 1990s that we discovered this endocannabinoid system. We said aha moments. In Israel, they did all this research, and they said, you know what? Maybe there is something to this cannabis plant. Maybe this is how it can work with these receptor systems. When I went through medical school, endocannabinoid system hadn't even been founded yet, right? So when you talk to medical students nowadays, a lot of the students still aren't being taught the endocannabinoids. How many people have heard of the endocannabinoid system? That's impressive. When I talked about this 3 or 4 years ago, nobody put their hands up. But you can still see not many people talk about this. Yet it's thought to be the most important messenger system in our body. It's a series of receptors called CB1 and CB2, and a series of messengers. There are proteins called anandamide and 2-AG. Think of eat, sleep, relax, protect, and forget. That's what this whole endocannabinoid system does. So if there's some sort of insult to our body, whether it's lack of sleep, inflammation, pain, anxiety, our body produces these chemicals to protect us. That's an intact, perfectly running endocannabinoid system. Here's how it works from a cellular level. Now, I'm going to talk about this for about the next 3.5 hours. I'm kidding. There are conferences that you go to, and this is all they talk about is the mechanisms of how the endocannabinoid system. But this is how crucial it is. If you can understand the endocannabinoid system, you can understand the potential for cannabis right off the bat. Okay? So the endocannabinoid system is a series of messages. It's a feedback mechanism. So think of it as dominoes. If you have a domino that has a signal, hits this domino, wants to knock over the next domino to pass that signal along, that's what happens. However, our body has sensors on it. The next neuron over, it produces these endocannabinoids, anandamide and 2-AG, if the signal is not a good signal. So if it's a seizure or anxiety or pain, then it sends back to that first domino and keeps it upright and stops that signal. That's a perfectly running endocannabinoid system. But you can imagine in arthritic pain and inflammation, and there's lots of studies on this, most of them mouse models, but if you look even in humans and you test the receptors, there's an upregulation of these endocannabinoid receptors in areas of joints with, don't use the word joint when I'm talking about cannabis, but the area of articulating surface, there's more receptors. So there's all these examples. What's the cause of fibromyalgia? We didn't know, right? Well, guess what? It looks like it's an endocannabinoid system dysfunction. There's research where they're looking to see people that can't produce enough of these endocannabinoids in the first place, fibromyalgia, migraines, irritable bowel syndrome, PTSD. These individuals, we never knew what it was. It was a lack of endocannabinoids. When you compare people with migraines, people that don't have migraines, with and without migraines, it's a difference. PTSD, survivors of the World Trade Center, it goes on and on and on. Did you hear that story about the woman that was in the newspaper a few months ago that feels no pain, right? She has an abundance of endocannabinoids. It shows us how strong of a painkiller anandamide is in this case. Normally it's broken down by enzymes and goes quickly away. She's missing the enzyme, so she has lots of anandamide. So she feels no pain, which gets her in trouble. But again, it just shows you the importance of the endocannabinoid system. So that's the boring part, but it shows you, the potential, because there's other things that fit into those receptors if we can't produce enough of our own endocannabinoids. Those other things are things like nabilone. So we heard all of the first hour about all the research that's been done on nabilone. Well, nabilone is only THC. That's a really important concept you'll see. We beat up on THC. THC is the one with side effects, right? Well, nabilone is the one that all the studies have been done on. We heard that. It's the plant-derived cannabinoids that we're all interested in, right? They also fit in those receptors. And then Namixabol is Sativex. It's a 1-to-1 ratio of THC and CBD. But as you heard, it's very, very expensive. Now, this is a picture of my basement. I do a lot of research. I'm very well versed in this. And that's my sister there. But it's the female cannabis flower that we're most interested in. If you look at a bud under an electron microscope, there's these juicy things called trichomes. Within the trichomes are the plant cannabinoids. So far, we've discovered 144 of them. We make maybe 2 up to 5 endocannabinoids. This plant makes 144. So talk about complexity, right? Remember about the research and the lack of randomized clinical trials. Very difficult to do on a plant that's this diverse. There's also things called terpenes in the plant. Terpenes give it the stink, the aroma, but it's thought that individual terpenes do different things. There's myrcene, limonene, linalool. They all have, some are sedating, some are more anti-inflammatory. We're just peeling apart this plant and learning what it can do. There's flavonoids, again, up to 500 parts to this very, very complex plant. Now let's talk about the 2 cannabinoids we know the most about. THC, of course, we know about. That's Cheech and Chong, right? THC is the stuff that makes people, giggle and dance like no other. But from a medical standpoint, it's a decent painkiller. It also can be sedating for sleep at night, and it's the one that seems to be the most useful for nausea and vomiting. But the rate-limiting factor is that psychoactive impairment. Now, recreational people like it. Medical people don't like it. People always say, what's the difference between recreational marijuana and medical cannabis? It's intent. What are you trying to do? If you're trying to have fun on a Friday night, you want the THC. If you're trying to get help but not get high, you probably want more CBD. So along we talk about CBD or cannabidiol. If you haven't heard from cannabidiol these days, I don't know where you've been living. It's on the front page of every magazine. It's on CNN, the CBD craze, National Geographic. It's like the cure for everything, right? It's the latest snake oil. So we have to dampen that enthusiasm, but it does look pretty appealing what the potential is. Because cannabidiol is not psychoactively impairing. When we heard some of this earlier talk about saying it can cause a nausea and vomiting, what we didn't hear was the dose. The dose that were used in those kids in the seizure studies were up to 20 milligrams per kilogram. I apologize, that's not correct. Up to 40 milligrams per kilogram. Thousands of milligrams of CBD. And it wasn't the CBD that was giving them nausea. It was the oil that they were taking it in. They were taking so much volume of oil, of course we'd poop our pants, right? It wasn't the CBD. When we look at it for CBD that we use in seniors and long-term care, it's a fraction of the dose that we were hearing that the harms of CBD, okay? So put that in perspective. So CBD, again, we heard, is useful for seizures, intractable epilepsy. It's also thought to be anxiolytic, okay? Also anti-inflammatory, minor painkiller. But the interesting part is the non-impairment. So absolutely correct. You can compound the two. If you have a person with a condition and they need THC, make sure they're taking CBD as well, because it can dampen down the psychoactivity of THC. But in broad brushstrokes, start with CBD. If you're a CBD responder, you don't even have to worry about THC, but it's all using the ratios of CBD and THC. That's where we're at right now. Stay tuned. There's 142 other cannabinoids we're going to find out about. Okay? So here's, again, we go to the evidence. What's interesting is, again, there's more than just poorly randomized clinical trials. There's a whole bunch of journal articles out there, and I suggest you just do a Medline research. But the one that I will look to, and most cannabis physicians will look to, is the National Academy of Science, Engineering, and Medicine. Okay? Their document, which these are all Nobel Prize winners, they'll say there's 4 conditions that there's moderate or conclusive evidence for. It's chronic pain, spasticity in MS, chemotherapy-induced nausea and vomiting, and the seizures and intractable epilepsy in children. Where the evidence is only moderate is in sleep, and especially if it's sleep where there's some inducing issue, whether it's pain or anxiety, even obstructive sleep apnea. If that's causing the sleep disorder, there's moderate evidence. I always like to say at this point, lack of evidence does not mean lack of efficacy. There's a big difference. And all you have to do, if you haven't had a family member or you haven't talked to somebody down the street that tells you it works for them, I actually laugh when I get patients come back to me and they say, you know, I've had a response, I'm really quite happy, and I go, that's impossible. They look at me, well, why do you say that? And I said, because there's no evidence. And then I kind of grin. But it's, so take it at that level. This is what we're faced with. I totally agree. There's not good double-blinded, placebo-controlled, randomized clinical trials. But this is where we're at right now. So here's the documents. Health Canada document suggests that if you're treating chronic pain and you've failed all the standard pharmaceuticals, then you can maybe consider cannabis. So Health Canada went so far as to say that. There is the document from the National Academy of Science, Engineering, and Medicine. I would suggest it's an 850-page document. I would suggest if you have difficulties with sleep, read the document. It's probably more effective than cannabis. Just read the document. But it's in there. They teased out all, not just randomized clinical trials, they teased out all the evidence. Okay? And they suggested, again, those 4 conditions. Now, here's interesting. Canadian Pain Society published guidelines in 2014 of how we should treat chronic pain. They looked at the evidence, and for the first time ever, they put cannabinoids in 3rd line. So they suggested things like anti-inflammatories, Tylenol, gabapentin, amitriptyline is 1st-line therapy. 2nd line, opiates. Remember, this is 2014. But 3rd line, the exciting part was they looked at the evidence and they said, we're going to slot in cannabinoids. So if the 1st line doesn't work, 2nd line doesn't work, then you can consider cannabinoids. Now, of course, most of us would look at this now and go, do I need to use opiates? Can I go to 3rd line? The guidelines are coming out next year. The rumor is that it's exactly what's going to happen. There's going to be a switch. Cannabinoids will go into 2nd place. For obvious reasons, opiates will go down to 3rd place. When you look at their data, that they looked at everything, they looked at NNT, the concept of number needed to treat. How many people would you have to treat to get an effective response? So an NNT of 1 means for every person you treat with that therapy, they'll get a response. There's no such therapy in the world. But a lower number, the better. So what came out the top was amitriptyline, followed by opiates, cannabinoids, 3.4. Now look at how the other ones show up. Look at how Lyrica, Tramadol, Cymbalta, look at gabapentin. We use a ton of gabapentin. Now let's look at the evidence. Not only there, that's all off-label for chronic pain. 99.2% of all prescriptions for gabapentin are off-label. There is no evidence for chronic pain. It's for post-herpetic neuralgia, and it's for seizures. So let's level the playing field when we beat up on cannabis and say, we need enough evidence. Let's actually see how, I'm not saying we're practicing great medicine, but it's kind of that's how we practice medicine. Most antidepressants in a McMaster University study were prescribed for things not for depression, They were prescribed off-label. So we're trying to hold cannabis to a different level of evidence than actually how we truly practice medicine. I'm not saying that's how we should do it, but let's level the playing field a little bit, okay? So if you ask across Canada to medical cannabis patients, what's the #1 reason they use cannabis? By far, you're going to see pain. If this was one condition they could pick, chronic pain. But again, that makes not a surprise. Chronic pain is the #1 reason people end up in emergency or in your office, and it only goes up as we get older. So why do they use it? Because cannabis is a different animal. When we see people with pain, quite often we'll give them a standard analgesic, and then they start to get constipated, so we give them something for constipation, and then they start to lose their appetite, and then lo and behold, they get depressed, so we give them an antidepressant, we need to give them a muscle relaxant, and they're not sleeping, it just goes on and on. So we give all these medications, we get this huge polypharmacy. Cannabis, because of where the receptors are throughout the entire body, has this unique ability to treat multiple things, because it doesn't just go treat the pain. It also goes to the receptors in the brain, etc. So it can help not only for pain, for our mental health and our insomnia, okay? Very interesting, and in the first hour, somebody asked the question, or there was a comment about people just don't seem to care about pain. That's absolutely correct. And it's not because they're impaired. They're not just stoned, they don't care, they can't feel pain, they can't feel their face. So a couple things. This again, different literature suggests different numbers, and this literature suggests a reduction of 3 points on the visual analog scale. Different than what we saw in the first hour. It's the disassociation of pain, though, that is fascinating. So I've been doing this for 18 years now. When I first started to get people back to me, when they report back, I'd say, hey, are you still in pain? And they go, yeah. I go, oh, I guess it didn't work for you. And they go, no, let me finish. I still have pain, but it doesn't bother me as much. I go, what do you mean? They go, well, it's not the same. And I thought, well, you're just stoned, right? You can't even explain how you feel. And it wasn't until one day one lady said to me, she said, Rob, it's like, I know my pain's still there, but I left it out in the hallway, I shut the door on it, and able to walk away from it. And it was that disassociation of pain, and it triggered. And it was a study done looking at the receptors. And this was a study done on mice. And so if we're at all like mice, so we can extrapolate. By the way, again, most of the studies are done on mice for ethics reasons and double-blind, blah, blah, blah. Mice have never been busier, I tell you. There's no unemployment issue with the mice these days. But this study, what they did is they took these mice and they rubbed Zostrix on their fur. They got really irritated. They don't like Zostrix, red hot cream. And they put them inside a functional MRI machine, a little tiny one. So a functional MRI machine shows off receptors in the brain that are active when something's going on. So if you're eating, this receptor will go off. If you're coughing, this receptor. Well, in this case, they were upset, so they were feeling pain. So the anterior cingulate cortex, where we feel pain, was lit up. So what they did then is they took these same mice out and they rolled this little joint. And they got, I'm not a big study person, okay? So I didn't read, I didn't read the whole article. So I might have gotten that a bit wrong. But anyway, somehow, maybe it was a bong. I don't know. But these mice had a moment together. They got cannabis into their system. They put them back in that machine, and it was like the mice were in a suntan booth, like they were sunning themselves. They didn't care. But what was really interesting was what part of the brain lit up was the amygdala. It changed from the anterior cingulate cortex to the amygdala. Amygdala is the area where we feel pain and we stress and emotion and fear. And it showed how many receptors we have for cannabis in those areas. So it's that disassociation of pain. You dang rights people live better with their pain. They're able to walk away from it. There's a better function, better quality of life. I was paranoid I was going to stone people. No, they get better function. Okay? This is based on my experience. There's not a randomized clinical trial in my office. These are people that sitting across from me, they don't care about meta-analysis. They want to get better. Okay? So, what's interesting is where the receptors are not. The receptors are not in the brainstem. Okay? So this is not based on a clinical trial. This was something I put together. So the safety of the lack of receptors in the brainstem. There's lots of opiate receptors. There's lots of receptors for benzodiazepines. So people stop breathing. Okay? This is the crisis. Not so with cannabis. That was misinformation, myth information, I call it, that people worry about overdose. Can you take too much cannabis? Yes. Are you going to die? No. Do you feel like you want to die? Yes. Well, you're going to get frustrated? Yes, because you're not going to die. It's dosing, okay? So what was interesting is years ago I used to negotiate with patients and say, look, if you're on an opiate, you're on codeine or morphine, we got to get you off that first before we can introduce cannabis. Because of safety, right? This could be worse. No, it's a parallel universe of receptors because of the lack of receptors in the brainstem. So Health Canada said, whoa, this is interesting. This is an additive effect. You can synergistically add cannabinoids to opiates, and it might allow you to reduce a person's opiate doses. That's where the studies are looking at. MJ Malloy and UBC is doing huge research on this. This is preclinical work looking at reduction of morphine by 3.5 times, almost 10 times reduction of codeine when you start to introduce cannabis to people on opiates. It's a big struggle to get people down off of opiates. We're looking at novel ways of harm reduction. We used to think of cannabis as a gateway drug, right? Now we're saying it's an anti-gateway drug. Very different. So this was a study across Canada, 21 clinics, observational study, but it was done by the physicians that were prescribing the medications. Because we don't want to just add cannabis to your mix. You're already on 6 medicines. Why make it 7? They were interested to see, would this reduce the medication burden? And you can see month by month, up to 6 months there, a reduction in opioids, other analgesics, antidepressants, seizure medications, sleeping pills, and muscle relaxants. Okay? When you dig through that data, in 6 months, there was equivalent of a 74% reduction of opiate doses. And these are the physicians that were prescribing it. It wasn't self-reported. These people, the physicians knew right away they were writing less triplicate prescriptions for opiates. That's pretty exciting, okay? So that's where this is looking at, could this be a potential help in the opioid crisis? So some of the smaller studies, but this is interesting because it was local, UBC looking at, what about mental health? There are very few studies on mental health, right, and anxiety. Dr. Allan was absolutely correct. There's very few studies. But this was looking at individuals with arthritis and how they felt with chronic pain. Again, mental health really takes a beating when people are in chronic pain. And what they did is they put cannabis versus anti-inflammatories versus opiates. Not only people found that it was more effective, the cannabis was more effective, which I thought was hard to believe that people would say it was better than an opiate for reducing pain, but they did. What was more interesting was how the pain was more bearable, normal life despite the pain, and less depressed about the pain. Okay, this is how people feel when that disassociation of pain. Okay, we talk about studies and say a lot of them were NNTs of 2. This is out of Israel, looking specifically at the elderly, just done last year, almost 3,000 patients, all elderly, all cannabis, all with various forms of cannabis, THC, CBD. This was actually done by Raphael Mechoulam's group. If you know Raphael Mechoulam, he's up for a Nobel, I think. He's the one that founded THC and was instrumental in the endocannabinoid system. But within this data, it's a very large document. It looked at analgesic efficacy. In their study, they saw that visual pain scale go from an 8 to a 4, so a span of 4 points. But as far as some sort of effect, some sort of improvement on their condition, it was 94% reported some sort of measurable response. Okay? That's a large study. That's not an NNT of 6. Okay? It's almost 3,000 people. Observational, though. Okay? What about the debate in cannabis and dementia and Parkinson's disease? And this is interesting because there is data that's starting to come out. It's been, as far as Parkinson's disease, it's been a real mixed bag. And when I see patients, I feel exactly the same. Some individuals don't respond at all. Parkinson's is hard to treat. We all know that. Some respond more to inhaled, some respond more to oral, some respond more to THC, some will respond to CBD. It's a real mixed bag in Parkinson's disease. There's a study down in San Diego going on right now looking at tremor, more essential tremor, using Canadian cannabis. First time ever it's been able to go across a federal border. So studies are being done on this, but it's really mixed in Parkinson's. Dementia, very mixed as well as far as the clinical trials, as far as has it done anything for, you know, cognitive improvement or anything like that. More interesting is how it works for agitation and the psychiatric symptoms of dementia. People tend to be calmer, less sundowning. So when I see patients in long-term care facilities, this is exactly what we're doing. So where's the evidence for antipsychotics, right? How many antipsychotics are used in our long-term care facilities? So more and more caregivers, family members are saying, can we try cannabis instead of Seroquel? And I think that's a good question. And I certainly, not a study, I've certainly seen very good results. And I wonder if some of you out there have as well, where it's been in the long-term care facilities. But I get feedback. I get referrals from geriatricians. I get often the nursing homes medical directors. And the feedback has been very promising and surprising. Again, not based on huge amount of data, but it's just kind of a logical thinking. Start with CBD, maybe add some THC if need be. Okay? The other thing that says early but looks promising is the things with dementia. Again, going back to the mice. Remember I said you can't own a patent on cannabis because it's a weed? There's actually one patent on the plant. It's the U.S. Department of National Health actually has a patent on the potential neurological implications of cannabis, so neurological regeneration. They are heavily studying, again, most on mouse models right now, the improvement in plaque formation. And even in mice, they're reversing the cognitive changes, but that has not been replicated in humans. But the signals are very, very interesting. How far are we away from that? Who knows? But that's the kind of the endocannabinoid system manipulation that's going on right now. And so the U.S. Department of Health is looking at that. Palliative care, it makes sense. Symptoms at end of life, we don't want to just snow people. We want better quality of life at end of life. And it can help with the symptoms of everything from anorexia to pain to nausea to sleep. Better quality of life. And again, this is a Health Canada document that suggests that that's an improvement. So again, a lot of us are used to prescribing Sesamet or Nabilone, but remember, it's just THC. So most of the side effects are going to be from THC. I would suggest, looking at a combination of CBD and THC. That is not a golf tee. Initially, it looks like a golf tee, but that's a joint in case you didn't grow up on Salt Spring Island. That's in case you've never seen one. But why is cannabis use in the elderly increasing? Because there's a lot of crowdsourcing and sharing, but elderly people have tried everything, right? So if there's ineffectiveness, intolerable side effects, they're asking about this, right? They're the #1 demographic in Victoria, but that's kind of biased because they're the #1 demographic, right? But they're the referrals that I'm seeing. I have a patient as much as 104 years of age on cannabis and doing quite well. But it can address those multiple symptoms. Also, elderly people, they've been through Woodstock. They might not have remembered, but they've been through Woodstock. So they've quite often had an experience with cannabis. They're not as afraid of it as we might be. Certainly cannabis can be stronger, and that's another myth that everybody says is, oh, cannabis is stronger than it's ever been. It can be, but it doesn't have to be. You can order cannabis as weak as Woodstock or as strong as Rockstar. Like it's variable. So when people say cannabis, what are you talking about? Tell me what's in it. So a lot of those studies that you heard about earlier too were mixed bags. Was it THC? Was it CBD? How was it strong? Was it? Nobody knows. They were poorly done studies. Okay. So it also, the reason it's quite popular in the elderly are things like societies, like MS Society, Arthritis Society. I don't know if you've seen this pamphlet, but this was sent out to all the members of the Arthritis Society. And it was about an 8-page glossy saying, take this to your doctor and see if you might be a candidate for cannabis. The trouble was, we physicians weren't prepared for this. We didn't have the education to answer the questions. And there was a lot of questions that said, ask your doctor what the studies show. Ask your doctors what dose. Ask your doctor about drug interactions. And if your doctor doesn't know those questions, Go to another doctor. Yeah, good luck, right? Where are you going to find another doctor, period? But that's what's out there. So that's why this is being pushed by patients. And we're in this unenviable position where we don't have a lot of education on this. The patients actually know more about this than we do. That's horrible. If it's asthma, hypertension, diabetes, we're good. Talk about somebody across the way from us and say, hey, doc, should I use CBD, THC? Should it be indica or should it be sativa? We just freeze, right? And we're like, no, there's not enough evidence. That's what we do, right? But the patients will push you a bit, push you a bit, push you a bit. So hopefully I can teach you a little bit now of how to be comfortable. I don't care whether you prescribe cannabis to patients, but I think you should have some information so you can have a good conversation with patients, okay? Because again, it's pretty bad when the doc knows less than the patient. That's the way it is with this. So what are the key concerns with older adults? Makes sense. Polypharmacy, comorbidities, cognitive abilities, physical abilities. So, they're at risk for anything that we give people in the long-term care facility. Cannabis is also a different animal altogether. It doesn't have a drug identification number. This was forced upon physicians to authorize. It was a judgment through the courts. We didn't take this willing, it just got foisted upon us. It's got so many different components. There's no product monograph. There's no dosing. How do we do it? Oh, it's simple. I'll show you. No. So what are the common questions, right? When should I consider it? It's not first-line therapy for anything. But if there's intolerable side effects or ineffectiveness from the standard pharmaceuticals, especially in those areas where cannabis has been shown to be effective, chronic pain being one of them, might be an opportunity to try it. What about the strain, administration, dose, and all the rest of it? Okay. Strain is easy. Pick CBD first. I alluded to it earlier. Whether a person responds to it or not, we don't know. But if you're lucky, they're a good CBD responder because of less side effects, all right? So pick CBD, conservative THC dosing or compounding. What about methods of administration? Well, it was simple up until this month. You could either inhale it or take it in an oil or a capsule. But coming this month, maybe into the new year, we're going to have edibles. We're going to have topicals. We're going to have concentrates. We're going to have vape pens. We're going to have patches.
Topicals are available already because I'm using them.
So you're illegal. Unless, are you making them yourself? I'll explain why it's illegal in just a sec. And people get mixed up on this all the time. But topicals, I'm a fan of topicals, but I'm just saying that right now they're actually illegal. So modes of administration when you take it inhalation or orally. So why did we even talk about inhalation, right? What a crazy concept for healthcare professionals to suggest putting anything into your lungs. And by the way, cannabis is a bronchodilator, so when that kid asked the question about using it for asthma, it wasn't a bad question. Not that we would give cannabis for asthma, but just saying. Anyway, in fact, they're looking at a dry powder inhaler using cannabinoids in it for asthma. So he knew what he was talking about. Once again, patient knew more than physician, and that's embarrassing in the cannabinoid world. But anyways, inhalation was the only way you could use cannabis from 2001 to 2014. That's the only way Health Canada allowed it. Not a good option. So from 2014 onwards, we have oral, whether it be oil or capsules. But there's a big difference between the two. I would say for the vast, vast, vast majority of patients, use the oral route. Makes sense. The only people that would benefit from an inhaled product would be if you need it quickly. Because an oral product takes about 60 to 90 minutes to kick in, but then it lasts for 10 to 12 hours. So it's a nice steady state. Whereas when you inhale it, either smoke it or vaporize it, it's in the system within 3 to 5 minutes and lasts for about 3 hours. So think of it as breakthrough. So you would inhale if you had a migraine coming on right now, if you had a panic attack, you had breakthrough pain. But otherwise, everybody else should be on an oral. Okay? Now, let's talk about the illegal over in the corner here. So there's all these other things that are coming out. Topical is interesting because it looks like, depending on the substrate you put it in, it's fairly localized. So we don't have to worry about systemic side effects if you put THC in it. CBD being the anti-inflammatory, THC being the better painkiller. If you put some of the strong, if you mix it with strong, it can be some systemic absorption. So some individuals were buying the oils or their flour and they're making their own butters and making their own creams. But there's 3 different markets in Canada, or there has been. There's the black market, which is easy to understand. That's buying it from me in my car afterwards. I'll meet you at 9 o'clock. It's the gray market everybody gets mixed up on. And healthcare professionals are guilty of this all the time. All those stores that you see on the street that sells whatever they want, those are the gray market. So they're shutting them down right now. They're called dispensaries, okay? They can sell creams, and they were selling edibles and gummies because they had no rules or regulations. There was no testing, there was no content, there was no quality control, but the Victoria gave them a business license. So they looked perfect, and to be honest, the topicals were good, but there's now federal regulations kicking in saying, you can't operate Wild West dispensaries. So now the green market is there. The green market is where licensed producers produce quality product. Every batch is produced in content, consistency of THC content, CBD content, like any medicine should be. And it's either shipped to the patient's doorstep for medical purposes, or it goes into the government-regulated recreational stores. Generally, the recreational stores are going to have more THC. Makes sense. The medical, you can get more likely CBD. Coming to a pharmacy next year, probably, that's the medical market. The pharmacists are being trained on this, mandatory training in Ontario for the pharmacists on this. So they're going to be stocking it in the pharmacy, which will make it even more normalized, right? So as healthcare professionals, we can say, go talk to your pharmacist, pick up this, okay? I think that's going to be a huge help. But I hope that describes, the fact that why you're going to jail right now is because of your topical. If you told me suppositories, I'd know exactly where you got those from, but no. So dosing is start low and go slow. So if you're starting with CBD, a general broad brushstroke is 2.5 milligrams at nighttime. I always start at nighttime because if a person's going to have any sort of odd symptoms, especially if they had no connection with cannabis before, start it at nighttime, like we do with most medications. If you're going to have to use THC, cut that dose in half. I mean, just be really cautious with the THC. Use it at nighttime, and then consider whether you have to use it in the daytime as well. Inhalation would only, again, be for breakthrough. And people say, what's the difference between a vaporizer and smoking cannabis? Smoking cannabis is where you burn it. Well, let's back up a little bit. Why do you have to even heat cannabis? That flower is in an inactive form. It's in an acid form. So you have to decarboxylate it and release the cannabinoids. But you don't have to burn it to do that. You can just simply heat it with a vaporizer. People right now should be going gasp because people are all concerned about vaping. The vaping that people are getting into trouble with is where they're vaporizing oils. The nicotine oils and all the rest of it. It's the vitamin E acetate. I was just on a conference call today. We're looking at this some more. Whereas the vaporizer I'm suggesting is a Health Canada product. It's actually authorized by Health Canada. There's 2 of them. And you put dried flower in, and it just heats it. It's 700 degrees difference between heating it in a vaporizer and burning it. So theoretically, it's easier on the lungs. But again, most people should be going the oral route. Another thing I should tell you, because the edibles are coming, and this is where people start to giggle, is beware of the baked goods. I'm going to look around the room very quickly, and I'm going to try and figure out who ate the magic brownie out there, because it should be kicking in about right now. Remember what I said is the brownie or the edibles, it takes about an hour to hour and a half to kick in. So the problem is people take a bite, and they only wait 15 minutes, right? So they're like, oh, there's nothing to this. It tastes good. And they keep eating, right, until the whole plate's gone, and an hour and a half kicks in, and they end up in emergency. So that's why emergencies, seeing these people, but there's nothing that they do for them. They reassure them and send them back home. Cannabis hyperemesis syndrome, by the way, was a question that came up in the first hour. So cannabis hyperemesis syndrome is where people get intractable vomiting. The only thing that reduces it is 2 things, is hot showers or Zostrix on the belly. The same Zostrix that upset the mice You put it on the belly, and some emergency rooms are actually stocking that. It's because of the screwed up receptors from the endocannabinoid system. And that is not from medical cannabis. That's from huge... Whoa.